All those things, we see that. And then I check my labs. Hemoglobin is low. Hematocrit is low, right? That already confirms anemia. Okay. Next thing, and see, and it doesn't, and you're gonna always take these steps, right? So no matter how the information is organized, you approach it this way always. See, don't read it the way it is given to you. I don't really care. In fact, when I look at it labs and I see it's anemic, anemia, I don't even read backwards anymore. I just follow this step all the time, so I don't get confused by any random information there or by distractors. Yeah. So once you say, okay, this is anemia vignette, next thing you're looking at your MCV, which you're probably going to be giving all the time. Or if they don't give it to you, that's fine. We have other things to kind of categorize them, right? Or determine what's going on. But I check my MCV, I'm giving MCV, then like you said, we divide into what? Micro, normal, right? And macrocytic, based on size or volume. If it's microcytic now, once I know it's okay, microcytic, of course, you have your differentials in your mind. Now, for each of them, I want you to master the mechanism, not just the causes. Know the mechanism of the anemia. Because once I know the mechanism, I can always come up with a differential myself based on the mechanism itself. It's going to be easier to come up with a differential diagnosis based on the mechanism of the anemia. So for microcytic anemia, it's caused by what? Anything that decreases what? Hemoglobin synthesis. That's the mechanism of microcytic. Central mechanism. Anything that decreases hemoglobin synthesis. And for me to make hemoglobin, I require what? Heme. And heme requires iron and porphyrin. And I require globin chains to make hemoglobin. So which means anything that affects iron, because microcytic. Iron deficiency, ACD. One is leading to deficiency, the other leads to trapping of iron. Iron is present but it's trapped. That's ACD. Anything that affects porphyrin synthesis, in the porphyrin pathway, maybe enzyme deficiency, ALE synthase, ALE dehydratase, ferrochelatase, whatever, and then as well as toxins, lead, inhibits porphyrin synthesis. Yeah, B6 deficiency, maybe from isoniazid use, inhibits porphyrin synthesis. All those will fall under what? Sideroblastic anemia. Anything that affects porphyrin, sideroblastic. Then things that affect globin chain synthesis, those are ones classified as what? Thalassemias, right? And since I have two types of globin chain in adults, hemoglobin alpha and beta, I can either say alpha thalassemias or beta, right? Thalassemias. Okay. Now, so which labs are going to be important to me under microcytic? Ion studies, electrophoresis, peripheral blood smear, bone marrow biopsy or aspiration. Those are the things that will be important to me under microcytic. Yeah, so which means if I'm dealing with microcytic, I don't have to interpret bilirubin levels. I don't need to interpret Coombs test. I don't care because I know my mechanism of microcytic. I know which labs will narrow it down for me, right? So one of those causes. So if iron study is abnormal, then automatically what? I forget thalassemia, I forget cerebroblastic. I'm focusing on either iron deficiency or ACD. Then I will now narrow it down further. Ferritin will be high in ACD, ferritin will be low in iron deficiency. TIBC will go in the opposite direction, right? To ferritin, like you said already. Yeah, I see that, I pick my answer, I'm done. Yeah. If iron studies is normal, then I rule out iron deficiency and ECD. I'm focusing on thalassemia or sideroblastic. Then they might give you peripheral blood smear. I'm looking at basophilic stippling O, right? Likely lead. Or I also see like neurologic manifestations, kidney injury, GI symptoms, likely lead for sure. Oh, I give you peripheral bone marrow aspiration. I see sideroblast, right? Definitely, you know, sideroblastic anemia. Then look for clue as to the cause, whether it's lead, if they have other manifestations of lead toxicity, whether it's B6 deficiency, if somebody is on isoniazid or something like that, whether it's congenital, if the patient has family history or it started right after birth. Yeah. Then if those are normal, Then I'm left with thalassemia, right? And in thalassemia, because sometimes you have to, actually for thalassemia, you can further divide thalassemia into what? Majors and minors. Majors are those ones where if it's beta thalassemia major, they have what? Only, they have almost less than 50%, right? Functional gene. That's why it's major. They're going to be symptomatic. If it's alpha thalassemia majors, the same thing. They have less than 50% functional gene, up to maybe even less than 75% functional gene. That's why they're going to be symptomatic. So basically, majors are symptomatic thalassemias. Minors are asymptomatic. They are just carriers of the mutation, but there is still enough functional gene, right, to dilute the effect of the mutation. So if I give you a patient, you suspect the patient has thalassemia, and the patient has normal electrophoresis, patient is asymptomatic, right? We see maybe target cells, microcytic anemia, right, on like screening test, incidental finding. Patient is asymptomatic, electrophoresis is normal. I'm dealing with what? Alpha thalassemia minor. Because in alpha minor, although the total quantity of alpha globin chain is low, the proportion of hemoglobins made is still the same. I'm still going to be making more hemoglobin A than A2 than F. So their proportion doesn't change, although the total amount decreases. Yeah. If I see a patient is asymptomatic, is also thalassemia, they're asymptomatic, we found the microcytic anemia incidentally. So we're thinking, okay, it's definitely, it looks like thalassemia with target cells on peripheral blood smear. No symptoms, but electrophoresis shows what? Low hemoglobin A. A is low by maybe like 50%. A2 and F, they are elevated. Then you're dealing with beta minor in that case. But if a patient is symptomatic from birth or in utero, actually, likely died in utero, hydros fetalis and stuff like that, you're dealing with alpha major. Those, they are incompatible with life because they have no fetal hemoglobin in utero, right? That's why you're going to see hemoglobin bars, right? Where you see gamma tetrads in their blood. If a patient presents with thalassemia shortly after, from as a child, shortly after birth, or maybe after like 6 months of life, right? Once the fetal hemoglobin level goes down, yeah, and then we check electrophoresis. Hemoglobin A is 0, basically. The other ones, A2F, they're super elevated. Definitely, you're dealing with what? Beta major in that case. Yeah. So as you can see, right, when we went down the rabbit hole, right, of microcytic, we are not thinking about any normal or macro because you're just going to be confusing your brain. Too much information, right? You're going to be all over the place. So by having that systemic approach that, okay, this is micro, I know my differential, these are the only things I'm thinking about. I don't care about any other thing they put in the vignette about any other cause of anemia except microcytic. That's it. Good? So micro. Okay. Under Normocytic, so I check MCV. MCV is normal. Normocytic has what? Has three central mechanisms. There are three possible mechanisms of normocytic anemia. First one is peripheral destruction of red blood cells, which is what we call hemolysis. That's the first mechanism of normocytic. Second mechanism of normocytic is decreased production EC. Then the third mechanism of normocytic is blood loss, acute blood loss, like hemorrhage. Because remember, chronic blood loss will lead to iron deficiency. Yeah. But if somebody is acutely bleeding, acute hemorrhage, normocytic. So those are the three central mechanisms of normocytic. Production EC, peripheral destruction, hemolysis, hemorrhage. Now, under hemolysis, I can go further. So let's take them one by one. Under hemolysis, you can further subdivide that into what? Based on location of hemolysis. Yeah. So is it intravascular in the vessels or it's extravascular in the spleen? So in all hemolytic anemias, reticulocytes will be high because because reticulocytes represent bone marrow function. So if I'm dealing with normocytic anemia and reticulocyte is high, I know I'm dealing with what I'm not. That rules out production issue. Yeah, it's not production issue. It has to be either hemorrhage, right, or hemolysis at that point. So if a patient has maybe otherwise normal vitals, they are not in hypovolemic shock, you can have maybe acute hemorrhage, you're dealing with hemolysis. Other things that may point to hemolysis is if you're not giving reticulocytes to be what? Jaundice. Patient has normocytic anemia and they are jaundiced. Bilirubin is high. Which bilirubin will be high? Indirect hyperbilirubinemia. That may be another clue that the patient is experiencing right hemolysis. Yeah, there's hemolytic anemia. Another clue I might give you to hemolytic anemia is actually if it's intravascular, is what hemoglobin urea. Hemoglobin is in the urine, right? Red blood cells have been destroyed, especially intravascular hemolysis. So I see pneumocytic and I see any of those clues, I'm not dealing with what? Right, hemolysis. If the spleen is enlarged, also likely extravascular. If the spleen is normal, it may be intravascular. Yeah, in that case. Another thing you might use to differentiate between intra and extravascular will be aptoglobin. So aptoglobin will be normal in extravascular hemolysis, but it's going to be low in intravascular, right, hemolysis. So I can go. So once I decide likely location, so let's take intravascular first. Okay, no, actually, this is what I do. Master extravascular. Anything that is not under extravascular exclusively is either intravascular or mixed, both intra and extra. So the ones that are definitely mostly extravascular, because even some of those extravascular causes they also have like intravascular hemolysis, but the ones that are where the hemolysis takes place mostly in the spleen will be HS, spherocytosis, IgG, autoimmune hemolytic anemia, and sickle cell disease. Those are predominantly extravascular hemolysis. Those three. Any other cause of hemolytic anemia is either exclusively intravascular or it's mixed intra-extravascular. Yeah, makes sense? So which brings us to under intravascular now under the list of orders, we can now put things like G6PD deficiency, PNH, right? Microangiopathic hemolytic anemias. Yeah, macroangiopathic hemolytic anemias as well. And so forth as PK deficiency, right? Primary kinase deficiency, and any other cause, right? Of hemolytic anemia you can think of. Malaria parasites, babesiosis, etc. They're going to be under the list of others. Yeah, mostly intravascular. Some of them are mixed. Yeah. So once I come down to that level now, and I need to look for specific things right, to tell them apart. The next thing will be what peripheral blood smear. So most of the causes of hemolytic anemia, you can differentiate them on peripheral blood smear because they all have different characteristic findings. Yeah, there's some overlap, but most of them actually they have specific findings. So if I see spherocytes, then I'm thinking either spherocytosis or IgG autoimmune. Both of them can have spherocytes. Then you look at the Coombs test. If Coombs test is positive, then there are antibodies, IgG, autoimmune. If I see spherocytes, Coombs test is negative, then I'm dealing with what? HS, spherocytosis. I see sickled cells. I know sickle cell disease. I see bite cells, Heinz bodies, G6PD deficiency. I see schistocytes, micro or macroangiopathic hemolytic anemias. Under microangiopathic hemolysis, you're dealing with DIC, HUS, TTP, HELP syndrome. So patient is pregnant, she has preeclampsia, and she has schistocyte HELP syndrome, liver enzymes elevated HELP. Patient is maybe a child or adult. There's preceding anemia, bloody diarrhea, now has liver disease, neurologic manifestation, sorry, AKI, neurologic manifestation as well as schistocyte, thrombocytopenia, likely HUS, Shiga-like toxin, right, from enterohemorrhagic E. coli. Patient is older, young, reproductive age, typically female, and she has HUS-like presentation. Also neurologic, thrombocytopenia, schistocyte, AKI, yeah, and but there's no preceding anemia, bloody diarrhea, right, before the manifestation. Yeah, likely TTP, right? Adams T13, right? Deficiency. Yeah, or antibodies against that. Yeah, and the patient has schistocyte. I also see increased PT, PTT, thrombocytopenia. INR is increased. Coagulation factors are low. Patient is probably bleeding from multiple orifices. Right, DIC in that case. If you can say go on, right? Yeah. I see ringed inclusions on peripheral blood smell, likely malaria parasite. I see Maltese cross-like inclusions, babesiosis. Yeah. So those are the hemolytic, right? Anemias. Good. Patient has normocytic anemia, reticulocyte is high, and vitals are unstable. Patient is in shock, hypovolemic shock state. Then you know it's hemorrhage or blood loss. Yeah, that's it. Um, I see normocytic with reticulocytopenia. Right. Patient has reticulocytopenic normocytic anemia. Then we're dealing with what? Production issue. Production. Under production issue, there are three mechanisms. You can further divide production into three mechanisms. So think of it as what? As a house, tenants, and the food those tenants eat. Right? So the house is the bone marrow. The structure of the bone marrow itself is the house. The tenants are the stem cells, erythroblasts, right? Or myeloid stem cells that occupy the house, the bone marrow, and their nutrients or what they will eat or what will keep them growing will be what? EPO, erythropoietin. So if anything goes wrong with any of those three things, right, that will affect, right, production. Make sense? Yeah, that's how you think about it. Now, another thing you can think about is if, let's say, the house is destroyed, right? Something's wrong with the house, but the tenants are alive and they still have nutrients. What can they do? They can relocate, right? Same thing in the body. If the bone marrow is destroyed, stem cells can leave the bone marrow and go where? To the liver and spleen or other flat bones to continue what? Extramedullary erythropoiesis. So one of the things I can do to probably narrow down the mechanism of reticulocytopenic normocytic anemia further is to look for what? Hepatosplenomegaly. The patient has reticulocytopenic normocytic anemia and I see hepatosplenomegaly, I know it's what? It's bone marrow destruction. Something is damaging the house. That's it. That's the mechanism. If I do not see hepatosplenomegaly, then I know it's either nutrient deficiency, EPO deficiency, or the tenants themselves, the stem cells, have been destroyed. Yeah, if the house, right, bone marrow is destroyed, stem cells will relocate to the liver and spleen. So you're going to see splenomegaly, hepatosplenomegaly, right, in that case, because the liver and spleen will take up, right, erythropoiesis to compensate. for bone marrow destruction, right? But if the tenants, the stem cells, or there's EPO deficiency, there will be no relocation anywhere, right? Yeah. So I won't see hepatosplenomegaly, right, in that case. Make sense? Okay. So if I'm thinking, okay, the mechanism here is likely bone marrow, maybe destruction, something's wrong with the bone marrow structure. Then you have your differentials like what? So infiltrative diseases of the bone marrow, things that are infiltrating the bone marrow that are occupying spaces, right? And pushing out the stem cells. Leukemias comes to my mind. Advanced lymphomas that have disseminated to the bone marrow comes to my mind. Disseminated systemic infections, TB, histoplasmosis, disseminated cancer to the bone marrow. Yeah. So all those things affect the bone marrow itself, the structure. And that's why presence of hepatosplenomegaly, right, in leukemia, right, is a marker of poor prognosis. Because the larger the spleen and the liver gets, it tells me that the more destroyed the bone marrow is. Yeah. If they are taking up more function of the bone marrow, it means the bone marrow is basically useless at that point. The cancer cells are so aggressive, they've infiltrated the whole bone marrow. Yeah, patient is incomplete, right? Like bone marrow failure. Then, if it's the causes of things that can destroy the stem cells itself, stem cells, if the stem cells are destroyed, myeloid stem cells now, it's going to affect every cell, right, in the myeloid cell line. Yeah. So we're going to say pancytopenia, of course, but then we're dealing with what aplastic anemia in that case. That's what we call aplastic anemia, where the stem cell, myeloid stem cells are destroyed, aplastic anemia. So every cell count low, including red blood cells, but you won't see splenomegaly because there's no stem cells to migrate anywhere. Yeah. And typically, aplastic anemia is what? Autoimmune disease. It's the T cells that are being activated, right, against red blood cells and myeloid stem cells, rather, in the bone marrow, and they're destroying the cells. And that can be triggered by medications. Sometimes can be idiopathic, we don't know the cause. Sometimes can be triggered by medications like carbamazepine, right, and some other drugs. It may also be caused by chemotherapeutic drugs, where the drug themselves are what cytotoxic, right? They damage the stem cells, yeah. Especially those chemo drugs that inhibit cell cycle, yeah. Sometimes only the red blood cell line is destroyed. You might see a type of aplastic or subtype of aplastic anemia where only the red blood cell is actually affected. The erythroblasts are the only ones affected. So like parvobinite. Also in what's the name? There's this condition, Diamond-Blackfan. Diamond-Blackfan syndrome is what? Is congenital, pure red cell aplasia. Only the red blood cell. Unlike Fanconi anemia, which is what? Congenital aplastic anemia. Because Fanconi will affect the myeloid stem cells, so every cell line is low. But in Diamond-Blackfan, it affects only the erythroblast. So only the red blood cells are low. Patients are anemic. WBC platelets will be what? Will be fine. Yeah. Then parvobin-19 to affect what? Only infect only the erythroblast and destroys them. So only the red blood cells will be low, patient will be anemic, but the other cell count should be normal. Yeah. Then EPO deficiency, right? The patient with CKD. Yeah. Patient with CKD, EPO deficiency, or if there's EPO receptor resistance, like Jack kinase receptor is not working or responding to EPO, then we're going to see also that will affect only the red blood cell line. Yeah, it's not going to affect the myeloid stem cell, only the red blood cell line. So patient will have anemia, but then you expect to see normal platelets, right? And WBC in that case. So that's your normal, right? Acidic anemias. Know your three mechanisms. Then I need to know how to kind of differentiate which mechanism I'm dealing with based on maybe presence of hepatosplenomegaly or not. Is the patient jaundiced, right? Reticulocyte count, is it normal or low, right? Or high? Yeah. So you can differentiate into one of those three mechanisms. And then under production issue, there are three further mechanisms under production issue. So I should also be able to narrow it down further into one of those three. Yeah. Like if I'm saying maybe pancytopenia, I know it's definitely bone marrow or stem cell. If I say only pure red cell aplasia, I'm thinking of maybe just EPO deficiency, diamond black fan, right? Something like that, or parvovirus B19. If I say splenomegaly or not, right, I'm thinking bone marrow or stem cells as well. So that, yeah, and once you have this, and you don't have to read you don't have to read the vignette like the way it's written. Once I know what I'm looking for, you're going to be looking for those things in the vignette. You can just scan through and look for them and let them guide you to your answer. That's how you approach anemia. Otherwise, they're going to give you so much information. They're going to be all over the place. Everything looks correct. Yeah. And that's what makes the vignettes look harder than they should be. So that's normocytic, right? What about macrocytic anemia? MCV is high. How do we classify macrocytic anemias? Okay. How do I recognize megaloblastic from non-megaloblastic? From what? Okay, what will you say on peripheral blood smear? We're gonna if it's megaloblastic. Mhm. Okay. What okay. What are hypersegmented neutrophils? How many segments? How many segments? How many segments would they have? They're gonna have more than five, right? Three to five is the normal, right? Segment of neutrophil nucleus. So more than five segmented nuclei or nucleus is yeah, hypersegmented, right? Yeah, more than five. So I see that I'm thinking megaloblastic anemia. So what are my differentials for megaloblastic? Oh, before we go to differentials, what is the mechanism of megaloblastic? Yeah, mechanism is what? Yeah. Okay, so impaired DNA synthesis. Yes, that's the mechanism. Impaired DNA synthesis, which will lead to what? Nuclear cytoplasmic, right? Asynchrony. Basically, the cytoplasm will be growing faster, right, than the nucleus. Yeah. Yes. Nuclear cytoplasmic, right? Asynchrony. If the cell cannot make DNA, right, the nucleus is going to be immature. It's not growing as fast as the cytoplasm is. The cytoplasm keeps growing, keeps growing, keeps growing. The cell keeps growing, but there is no mature nucleus, right, to trigger, right, proliferation or cell division. So that's why those red blood cells look very, very big. Yeah, megaloblasts. All right, what are the causes of megaloblastic? B9, B12, what else? Uric aciduria, what else? Uh, it's also chemo drugs. Yeah, because chemo drugs, right? Especially those ones that inhibit DNA synthesis. Yes, they can also cause megaloblastic. Yes. There's also what you may also see megaloblast in myelodysplastic syndrome. It's just something I want you to keep in mind as also a differential for just having megaloblasts or hypersensitive neutrophils in myelodysplastic syndrome. Although it's a cancer or precancerous, it's a precursor to leukemia, right? But they can also have megaloblasts. So that's another differential. So B9, B12 for sure you must know. No orotic acid, right? Then no chemo drugs like hydroxyurea and stuff. And then also myelodysplastic syndrome would be another differential, right, for having megaloblast or hypersegmented neutrophils in the blood, especially if the disease is refractory to treatment. Yeah, it might be myelodysplastic. So how will B9 and B12 deficiency lead to megaloblastic anemia? How does B9 and B12 deficiency impair DNA synthesis? What binders? No. I'm not asking what is the cause. I'm not asking what are the causes of B12 deficiency. I'm asking so somebody is already deficient, right? From whatever reason, patient is already deficient. How will B12 lead to megaloblastic now? The consequence of the deficiency is megaloblastic, correct? So how will B12 lead to megaloblastic anemia? You told me the mechanism of megaloblastic is what impaired DNA synthesis, right? So I'm asking you, what role does B12, and B9 normally play in synthesizing DNA? So that when they are deficient, right? So DNA is not being made anymore, and that will lead to megaloblastic, isn't it? Yeah. So what role do they normally play in DNA synthesis? How, how do you synthesize? How do you synthesize DNA? So what do we need to synthesize DNA? Nucleotides are the building blocks, right? For DNA synthesis, and then we need other enzymes like DNA polymerase and stuff. Okay. What are the nucleotides we need for DNA synthesis? We need what? What are the nucleotides? Hmm? Right. Right. You are both wrong. Right. I asked you what are the nucleotides. Right. That's how we fail board questions. You mentioned the nucleosides and the bases. Exactly. Now we're talking the phosphorylated forms. Right. So the phosphorylated, right. ATP, TTP, GTP, CTP, UTP. Sorry, not UTP. UTP is for RNA, right? Right. For DNA, TTP, ATP, CTP, right? GTP, right? Right? Okay. All right. So how how will I synthesize TTP? And actually, I'm also wrong though. For DNA, we need the deoxy nucleotides, not the right? Deoxidized ones, right? Remember, DNA is deoxynucleic acid. Yeah. So actually, I need deoxy TTP, deoxy DTP, deoxy CTP, right? And deoxy ATP, right? Deoxidized. Yes. The deoxys nucleotides. That's what we actually need, not the nucleotides themselves. Because the nucleotides are for RNA, but the deoxynucleotides are actually for DNA, deoxynucleic acid. Yeah. You said? Yes, exactly. Yes. Yeah. All right. So how do we make the nucleotide? How do we make TTP? Right. Right. So, but how do you make the thymidine in the first place? How do you make thymidine, the nucleoside? We make TMP from what? We make it from UMP. Yeah. We make TMP from UMP. And also make CMP from UMP in the pyrimidine pathway, right? Pyrimidine synthesis pathway. We make TMP from UMP. We also make CMP from UMP. In other words, in pyrimidine synthesis, I'm going to make UMP first. That's the first pyrimidine I'm going to make. To convert uracil to thymine, I need to what? To methylate uracil. So I'm going to add a methyl to UMP, right? To form TMP. Then I'm going to add an amino group to UMP to form CMP, cytosine. Yeah. But to form TMP from UMP, right, I need to methylate uracil, right? So thymidine synthase enzyme, the enzyme that synthesizes TMP from UMP called thymidine synthase or thymidylate synthase. That enzyme requires what? Methyl group. Requires methyl to work. So who will donate the methyl? Who will carry and donate the methyl to thymidine synthase? Is gonna be what? It's gonna be methylene tetrahydrofolate. Methylene, right? Tetrahydrofolate is the carrier of methyl. That's why they call folic acid, right? A carrier of what? Single carbon molecules. Because methyl is single carbon, CH3, right? It only has one carbon. So that's the major function of folic acid in the body. It carries and stores, right? Single carbon molecules like methyl, methylene, etc. And it can donate them, right, to reactions that require, right, methylation. Too much information, right? All right. So B9 gets into the body, right? B9 gets into the body. It's not active. We need to convert it to what? Active form. The active form of B9 is what? THF, tetrahydrofolate. Good. The enzyme that converts B9 to THF is what? Is dihydrofolate reductase enzyme. Dihydrofolate reductase will convert B9 folate to tetrahydrofolate, THF. Tetrahydrofolate will now what? Bind to methyl to form methylene tetrahydrofolate. You get it? So that methylene tetrahydrofolate is what? Is the storage form. Is the stored form of folic acid. Is the form is going to be stored in the body. Methylene tetrahydrofolate or methyl tetrahydrofolate. There's also formyl tetrahydrofolate, right? Different types of some carbon, but just know that tetrahydrofolate bound to any of those single carbon molecules, right? That's the stored form. Now, we use the single carbon tetrahydrofolate, right? We're going to use them. So it's basically carrying molecules that are required by reactions, right? So if I have a methylation reaction, a reaction that requires methyl, like TMP synthesis reaction. TMP synthesis reaction requires methyl. So where will I get the methyl from? I'm going to get it from methylene tetrahydrofolate. Yeah. So methylene tetrahydrofolate, that is B9, will donate, right, that methyl to UMP, and UMP becomes what? TMP. So if a patient has B9 deficiency, right? Somebody has B9 deficiency, what happens? Exactly. Right. There's no methylene tetrahydrofolate. There's no methyl for what? TMP synthesis. If there's no TMP, can I form DNA? No. That is how B9 deficiency, right, impairs DNA synthesis and leads to megaloblastic anemia. Clear? All right, so we've answered half of the puzzle. So what's the deal with B12? What's the deal with B12? Yeah, what's the deal with B12? B9 can cause megaloblastic anemia. So how does B12 cause megaloblastic anemia? What's its deal? We get B9 is doing an important function. We know what it's doing. So what is B12 doing exactly? Is it codependent? That's histrionic personality, trying to steal the limelight from B9. So here's the link, right? B12 can transfer methyl. That's the link. So B9 can store and donate methyl, right? B12 can transfer methyl. Now, if I ask you guys, where will B12 collect methyl from to transfer? It's going to collect it from B9. That's how they are linked. And they are linked in what? In methionine, right? Synthesis pathway. So for me to synthesize methionine, right, I need what? I need to methylate homocysteine. Ross, you okay? All right. Can you hear me now? All right. So where does B12 come in? So there's a reaction called, methionine cycle, right? Methionine synthesis pathway. How do we form methionine? We form methionine from homocysteine, right? Homocysteine. There's an enzyme called methionine synthase, which will convert homocysteine to methionine. To form methionine, you need to methylate homocysteine. You need to add methyl, right, to homocysteine to form methionine. Correct? Good. Now, where will methyl come from? From our knowledge so far, where will the methyl come from? From B9. Beautiful. The problem here is that B9 cannot directly, unlike the TMP synthesis, right? Where B9 can directly donate the methyl. In methionine case, B9 cannot directly donate the methyl, right, to homocysteine. It requires what? It requires an intermediary, a mediator, which will be B12. So B9 will transfer the methyl first to B12, and then B12 will now transfer the methyl to what? To homocysteine. And then homocysteine becomes what? Methionine. Oh, yes. When when B9, right? When B9 transfers methyl to B12, what happens? I'm going to convert I'm going to regenerate what? DHF, right? So B9 becomes the inactive form, either B9 or dihydrofolate. And I need to what? Convert the hydrofolate back to what? THF, right? And then add another methyl to restore, right, the storage form of methyl. So in patient with B9, in patient with B12 deficiency, what happens to B9? B9 gets trapped. It's going to be trapped in the form of methylene tetrahydrofolate or methyl tetrahydrofolate. You cannot recycle it. It's going to be trapped. If it's trapped in that form, right, no reaction can be used. Other reactions that require methylation, right, they're not going to work because there will be no B9. B9 will be stored, trapped in that storage form. So reactions like TMP synthesis that require what? Methylene THF, right, will not work. They don't have methylene THF. And that also leads to megaloblastic, right? Anemia. So that's why somebody can have megaloblastic anemia even in the presence of B9. Even if they have B9, right, they can still develop anemia if B12 is missing because all the B9 will be trapped in the form of methyl B9 tetrahydrofolate. So I will not be able to recycle tetrahydrofolate, right, and form what? Methylene tetrahydrofolate, which I need, right, for TMP synthesis. Yeah, right. So or whether directly or indirectly, right, they are both inhibiting, right, DNA synthesis. They are inhibiting TMP, right, synthesis, and that will lead to megaloblastic, right, anemia. Excellent. How will you differentiate between B12 and B9 deficiency, presentation wise? B12, I think, has neurological manifestations. What kind of neurological manifestations? B12 deficiency damages what? The spinal cord, right? It's going to damage the dorsal column, damage the lateral corticospinal tract in the spinal cord. So how will a patient present in that case? Damage to the dorsal column will have lateral proprioception, lateral column. Yeah. What else lateral column? Yeah. They're gonna have a weakness for sure because of corticospinal tract. Okay, so they're gonna have upper motor neuron, right? Lesion because of the lateral corticospinal tract, right? Damage, hyperreflexia, hypertonia, Babinski sign, right? And they're gonna see loss of proprioception, position sense, vibration sense because of damage to the dorsal column. Excellent. Yes, sir. Okay. Biochemically, how can we tell them apart? Okay. Okay. Why will methylmalonic acid be high in B12 deficiency? Okay. Which enzyme catalyzes that? Methylmalonyl, right? Mutase enzyme, right? Mutase, which is like an isomerase enzyme. It's gonna convert methylmalonyl CoA, right, to succinyl, right? CoA. Yeah. So methylmalonic acid will be high in B12 deficiency, but it's going to be normal in B9, right? Deficiency. Both of them will have what? Increased homocysteine, right? Levels. Homocysteine will be high in both of them. Methionine should be low in both since, yeah, they are affecting methionine synthase, right? Enzyme. Yeah. Okay. Why will a patient with either B9 or B12 deficiency present with stroke, MI, atherosclerotic cardiovascular disease? Why? Nothing? Okay. Do you know? Go ahead. What's on your mind? Yeah, it's possible. That's why people with B9 B12 can actually have pancytopenia, right? Yeah, can affect all the blood cells. They can have pancytopenia. Yeah, there's no DNA synthesis. So that's possible. Yeah, but the answer is homocysteine, right? Remember homocystinuria. People with homocystinuria, right? Where there's congenital deficiency of cystathionine synthase or methionine synthase, and they have homocystinuria. How do they present? They have this mafanoid appetite, right? However, what happens? What do they have? I won't say Marfan syndrome, right? Premature cardiovascular disease, right? They have MVP, they have coronary artery disease, MI, stroke, things like that. Yes. Why do they have that? It's because of homocysteine. Homocysteine can damage endothelial cells, which can lead to atherosclerosis and platelet thrombus formation and things like that. Yes, clot formation. So the same thing. If depending on how bad B9 or B12 deficiency is, and how high homocysteine is, right? Those patients might be at high risk for cardiovascular disease, right? Yes, atherosclerotic cardiovascular disease because of homocysteine. Mhm. Got it? Okay.
Dapat kuat still. Like we were saying, you have to control. It's converted to TNP and your P is converted to TNP. It's the pixelation, right? What is deoxy? The deoxy. So what will convert? What's the precursor of the ATP and GTP?
So ATP and GTP are from the word purine synthesis pathway, right? Purine synthesis. Yeah, so they have like the mechanism of purine synthesis is a little bit different from pyrimidine. So they actually don't have, they are synthesized from the onset, like they don't have like precursor per se, no. They are synthesized as the purine synthesis will synthesize adenosine, guanosine, right? They just right, and then they are converted to deoxy by a reductase enzyme. Yeah, but they don't have like a precursor molecule like UMP, right, which will convert them to something else. No, so they are synthesized from the onset in that pathway. Yeah, yeah. And you know that in pyrimidine synthesis pathway, right, the precursor for UMP is actually what orotic acid. Right, that is why orotic aciduria, where there's a deficiency in what I think UMP synthase enzyme, or right. So there's a block, right, in converting orotic acid to UMP. So orotic acid will be high, UMP goes down, TMP goes down, CTP goes down, right? And DNA synthesis is also impaired, and that's why you can also see megaloblastic anemia, right, in orotic aciduria. Yeah. All right. Then chemo drugs that can either that inhibit pyrimidine synthesis, inhibit purine synthesis, or right, or inhibit any other part of DNA synthesis, right? They can also cause megaloblastic, right, anemia. Yeah, that's why hydroxyurea for treating sickle cell disease, right? It may be complicated by it may cause megaloblastic anemia as a side effect of using that drug. Yeah, so that's something we also need to know. Okay, what are the non-megaloblastic anemias? Non-megaloblastic. What are they? Okay, liver disease. What else?
Alcoholic.
Okay, liver disease, chronic alcohol use, hypothyroidism. What else? Asplenia. Yeah,
Okay.
asplenia.
I think MS falls under that too.
Which one? No. Multiple will cause normocytic anemia. How will multiple myeloma cause normocytic anemia? How? It causes normocytic anemia, right? So how? How do you think MM would, out of our three mechanisms of normocytic, which one would MM?
That would be production issue.
Production issue. Yes, it's production issue. So out of the three production issues, which one? Out of the three mechanisms of production issue, which one? It's gonna be. Alright, so bone marrow is made, right? Plasma cells can infiltrate the bone marrow, right? Yeah. And that may cause, okay, that's one. Actually, it can use all three mechanisms. That's the thing, all three. So the plasma cells themselves may infiltrate the bone marrow, and yeah, they may occupy space, and that may overcrowd these stem cells. That's one. Secondly, but I don't think that's the mechanism. The reason I don't think that is it is because people with MM don't actually have pancytopenia, right? they only have anemia. Platelets and WBC, they are usually normal. Yeah. So I don't think
So
it's
it
bone
means
marrow
they need
infiltration.
EPO.
Right. So the primary mechanism is so it's called EPO because remember it causes CKD, the myeloma, the Bence-Jones proteins. Good. So it causes CKD, which leads to EPO deficiency. Then the second mechanism is that it also releases what cytokines. The myeloma cells they release interleukin 6, OAF, etc. Yeah, which I think interleukin 6 itself is like it's a cytokine that can inhibit I think EPO function and stuff like that, right? And that may contribute, yeah, to the anemia. But EPO deficiency for sure, right? I think is the primary mechanism. That's why they only have anemia. All the other blood counts, right, is usually normal, right, in MM. So that is that. All right. Yeah. So for non-megaloblastic, for sure, the mechanism for non-megaloblastic is usually this word: increase surface area, right, to volume ratio. Increase surface area to volume ratio. I think anything that prevents splenic macrophages from removing, right, excess cell membrane from the red blood cells, so they appear bigger, right, than normal because of that. And you might also like target cells in non-megaloblastic, right, on peripheral blood smear. You might say our jolly bodies if it's due to asplenia, our jolly, which are ribosomal remnants, right, RNA remnants in the cytoplasm. Yeah, so you might see that patient with chronic alcoholism, yeah, you're gonna see megaloblasts, you might see target cells, but they may also have other features of liver disease, like increased AST, right? ALT ratio, things like that, elevated GGT, pointing you to okay, there must also be thrombocytopenic because of TPO deficiency, as well as trapping of spleen in the of platelets in the spleen also might contribute to that. So yeah, you look for additional features to just differentiate them. If it's hypothyroidism, you see other features of hypothyroidism, hyporeflexia and constipation and weight gain, without changing appetite, things like that. So just look for additional features to narrow it down right further. Yeah, but that